Marilyn and Fulvio made my life easy. So this is a practical session. So thank you very much for coming. So before I start, how many of us not specialize in allergy? Just show of hands so I know the audience. Not specialize in allergy, yeah? Okay, so most of you specialize in allergy. Okay, great, thanks. So this is basically a practical talk. I'm going to be sharing two cases. I'm going through how do we diagnose allergic rhinitis in clinic from the history perspective, from testing perspective, and how that will going to benefit us to decide on the right treatment for the patient. So the immunotherapy or the personalized therapy. So once I have the slide ready, then I can go. Thank you. So this is kind of the learning objective. Based on the history, based on the skin prick testing, and the investigation we're going to do in the clinic, how can we decide about the right management for the patient? Are you okay to go here? So I'm going to start with two practical cases. That's what we see in clinic. I've got two referrals here. The first one is a young lady. She came to us with a referral of, is this an allergic rhinitis or not? So she has asthma, but she has adult onset asthma. And she had 3 different operations previously for nasal polyps. So the question, is this allergic rhinitis or not? The second patient is a male, young patient with, again, a question, is this allergic rhinitis or not? But this one has a childhood onset of asthma, atopic dermatitis, and recently moved to a university accommodation, and his symptoms got worse. So that's kind of the two different scenarios we're going to be exploring throughout our talk today. So to start with, when we're assessing a patient with a question mark of rhinitis, there's a few things usually we go through. And the first thing, obviously, the history. And based on the history alone, we can say this patient probably have allergic rhinitis before even doing a diagnosis. And that's basically increase your probability of actually identifying the right patient to get the right treatment for them. So from the atopic history, from the exposure, from the drugs, and here you have got 85% of the diagnosis already. When you come to the skin prick testing, you try to confirm what you're already suspecting. It's not you do a skin test for everyone, obviously, to kind of figure out if they are allergic or not. Because if you've done a skin prick test for all the audience here, I think maybe more than 50% of us have a sensitivity, but not an allergy, which is quite important. Following that, we sometimes need to do further testing, like blood testing, to confirm what we have done already, or the skin testing was not possible because of other problems. Sometimes patients have what we call dermatographism. So we cannot do skin tests because that would just come up. Or they're receiving immunosuppressions, or they're receiving antihistamine, they cannot stop them. So we can go to blood testing. And blood testing, obviously, you've got lots of panels currently and lots of platforms. The common one we use is Immunocap, but there's multiplex and basophil activation tests and a few others, which we're not going to talk about it today. And then following that, you come to the right treatment for this patient. Start with the education and then personalized therapy. So, and why we all talk about this allergic and why we worry about it. You already seen Marilyn and Dr. Fulvio talked in details about the burden of allergic rhinitis and the consequences of allergic rhinitis. This is just one of the studies showing that children who have multiple sensitization, they can develop asthma. And you've seen that beautifully with Dr. Fulvio, the detailed few studies he mentioned. So that's why we're trying to diagnose those patients early, treat them early so we prevent complications later in life. And the worst complication, they can develop severe asthma, which can affect their quality of life remarkably. So the question, does every patient with cough need allergy testing? I think probably most of you agree with me. This is not right, because cough can be for many reasons. Let's go through step by step from the history and how we're going to go through this. So based on the history, and you've seen case 1 and case 2. Case 2 have got atopia, have got a lot of atopic condition, which probably raise the susceptibility of having a allergic rhinitis. Classically, those patients going to come with rhinorrhea, with nasal blockage sometimes, post-nasal drip, itchiness, sneezing, and few other symptoms, all will be related to the nasal cavity. The important point in the history, when you figure out where we are with this patient. Does this patient have a mild, intermittent, occasionally, or a moderate, severe, or are we talking about persistent? And based on that, you're going to decide about the therapy. Because if you have got somebody mild, you can just treat them with patient education, a bit of symptomatic treatment, and off you go. But you've got severe daily symptoms affecting the quality of life and work, you're going to be thinking about personalized therapy, and that will be immunotherapy and beyond. And the triggers are very important. So classically, the patient come to you, oh, doctor, I'm allergic to perfumes. I'm allergic to smoke. Whenever I go to any perfume shop, I cannot, go there or wash or I cannot work. I cannot do anything at work because all the people come to us with perfumes. And obviously, in this country, we love different types of perfumes and bakhur. So this is, of course, not allergens. These are triggers. So when I say triggers, is the patient already have the allergy, for example, house dust mite, pollen allergy in the background, and obviously these are chemical irritant rather than allergic symptoms. And those triggers can not only be for allergy, so it's not only if you have got allergy to perfumes or smokes or trigger symptoms. This does not always mean allergic rhinitis, because there's a lot of other conditions like vasomotor rhinitis and few other rhinitis can be triggered by these chemical triggers. So determining the trigger is quite important. And classically, patient move to, for example, they go to a hotel with lots of carpets, probably going to be thinking about house dust mite. But somebody goes to their farm with animals, you're going to be thinking about animal allergy. And again, the timing, as you already seen before, the timing, whether there is a seasonal variation or is it throughout the year, again, this is extremely important. When it comes to comorbid condition, this is quite, again, supportive to what we're talking about with regards to allergic rhinitis. If somebody came to me with already atopic dermatitis, we've got asthma, I would expect they're probably going to have allergic rhinitis. Not all the time, but that's kind of supporting what we have. But there is other complications of allergic rhinitis, which again, make us kind of think, what else we could offer for this patient apart from just a symptomatic treatment or immunotherapy, and those who have got sleep disturbances and other problems can be developed. Nasal polyps is quite a challenge one, because is the nasal polyps driven by the allergic rhinitis, or is that driven by eosinophilia? And of course, that's a whole discussion about what the best treatment for this patient, because at the moment we want to find out what the right treatment for this patient. We want to figure out, are we just going to give them a symptomatic treatment? Are we going to go with the pathway of immunotherapy? Or are we going to be thinking about biological therapy? And this is really important, because once you get the right treatment for the patient, we off you go. I mean, the patient will get better, and you've got an impact on the patient quality of life. Other complications like hypothyroidism, like hypothyroidism and sarcoidosis can present with similar presentation, but they are not allergic, of course, causes. Now, when it comes to family history, and this always the patient asks you, oh, my dad have allergic rhinitis, my mom have allergic rhinitis, my sister have allergic rhinitis, I probably have allergic rhinitis. Obviously, it doesn't, as you know, it doesn't work like this directly, but we know if you have got the susceptibility from the genetic perspective, you might have high risk of developing allergic rhinitis. But then if you have got new animals, so I had a patient recently, they bought a small deer, very small deer in the house, but within 2 weeks, all the house start coughing. And they're thinking why they start have cough. Obviously, the deer is the main driven for that, which is quite interesting. Environmental exposure. Obviously, we already talked a lot about the climate changes and all what we're having, but we can see here the environmental exposure is a drive for so many of these allergic rhinitis, and particularly people working in either their hobbies or the nature of their work, working in places where it increase the risk of developing allergic rhinitis. Right. So from the history now, we know this patient have got atopic dermatitis, have got asthma, or they have got symptoms and signs, symptoms suggestive of allergic rhinitis. So this is in the allergy clinic, in the primary care or non-allergy clinic, thinking whether any of these patients might have allergic rhinitis. So when we go through the first kind of step here, if they have got 2 or more of the following symptoms for more than 1 hour for most of the days, here we're kind of thinking whether this is allergic rhinitis or not, and from there we can classify intermittent, persistent, and so on. But if you've got any of these symptoms, which is sometimes a lot of us in the allergy clinic get the referral, these are unlikely to be allergic rhinitis if you've got a clear obstruction or a clear epistaxis, anosmia, and other symptoms. Although anosmia can sometimes be temporary kind of symptoms. Right. So we've got this history, we've got the science, and now we're going to come to the actual demonstration of the IgE allergy in the clinic. I'm going to spend a few minutes here because this is really important. When we compare immunoassay, when I say immunoassay, all kind of immunoassays, multiplex, monoplex, basophil, so all the assays that we do in vitro to diagnose allergy, and then skin prick test, which is the test we do in the clinic. So when we talk about immunoassay, so here is just not a comparison head-to-head, but it's just to kind of see what that will give us and what this will give us. So when we talk about immunoassay, the main thing with it does not influence by medication. If the patient taking antihistamine regularly and cannot stop them, or taking a steroid or any other things, they most of the time would not be affected unless in certain immune disorder, which we're not going to talk about it today. And again, not influenced by skin disease. Obviously, if I've got any kind of skin disease, does not influence the assay itself, but does influence the interpretation. And this is really important. I'm going to explain this in a few minutes. Quality control possible. Obviously, that's the lab language. So those assays have to be in a recognized lab, a lab that have got accreditation and can be trusted, because there's so many private small labs right in the beach. They do some assays and that might not be accurate. And this is really important. The quality control of the lab is extremely important. Now, immunoassay, a little bit expensive compared to skin prick testing, but the interpretation requires expertise. And this is really important. A lot of patients go to a clinic somewhere in a primary care, in a lovely villa somewhere in a private hospital, and they come with this list of investigation, tested all kind of IgE in the world. So it'll be IgE to pork, to lamb, to hives, to olives, as well as grass pollens and house's mite. This is really important. This patient might have eczema, and we know eczema increases the total IgE. So the total IgE can be 3,000, 4,000, 6,000. Now, when it comes to interpret the specific IgE, that would be the problem, because those patients can have all of them positive if we're going with the cutoff of 0.35. If we're going to get with the cutoff of 1, most of them will be positive. Does that mean allergy? And that's a very important question. And that's the whole idea of actually integrating the history with the science we have with the blood results. Positive blood test does not mean allergy, as we all know. And just to confirm that positive blood test is a sensitization, and we have to link that with the history. When it comes to skin prick testing, it's more sensitive. We have immediate results, especially somebody come to me from the Northern Emirate to here, driving 3 hours. I would love to do skin test for them today and just tell them, listen, this is what you have. Let's start the treatment symptomatically and see how we're getting on if we need to have immunotherapy. Require expertise to perform the interpret. This is, again, very important. We've seen throughout when we training people, or we've seen other doctors doing it. Obviously, the skin prick test itself, to do it, need expertise, need some people who knows how to do the skin prick test, not using the same. We've seen a doctor using the same lancet for all the drops, which obviously all came back positive. And this is really important, those little kind of techniques. But the interpretation is, again, very important. If you have got all of them 2 millimeter, 3 millimeter, are you sure you're dealing with a right kind of results, or do we need to have a proper wheels? So the interpretation of skin prick test, again, affected by many other factors. Some people can be taking other medication that can affect the interpretation of skin prick test, like antidepressant medication sometimes, or painkiller medication can affect the actual positivity of the skin prick test. So the bottom line from this slide is, we know from the history, this patient have high probability of allergic rhinitis. Then based on the history, with a bit of support from the testing we did, then we can say this patient, yes, does have allergic rhinitis. Now, there's many other things as well affect the immunoassay, and I'm just going to mention this just for you to know. When you have a blood test and that's positive for all kind of pollens, all kind of fruits, and few other things, we kind of be confused. Is this patient allergic to all these fruits and allergic to all these pollens? And this is what we come to something called component resolved diagnostic. I mean, this is, of course, been available for the last more than 10 years now. People using it. I think here in the UAE, We're not using that much of it, but hopefully we'll get that here. These are shared pollens, proteins between the tree kingdom, the plant kingdom. So just put it here in a clear picture. So if you see the top here, we call it profiling. So these are labile protein, and that's shared by many pollens and many fruits and vegetables. When it comes to PR10, that's pathogenesis related 10, those patients can have allergy to pollens as well as fruits, and they can develop mainly develop local symptoms. We call them oral allergy syndrome or pollen food syndrome, but they can develop systemic symptoms. And this is extremely important to remember. Usually the protein present in the pulp of the fruit. When it comes to the LTP, that's the lipid transfer protein, that's number 3 here. And those patients are very scary patients. This is my worry when I have those patients, because the LTP is a very stable protein that does not affect by heat or any of that. And those patients with a beta cofactor can develop systemic symptoms. When I say cofactor, like exercise, for example, classical example, wheat-dependent exercise-induced anaphylaxis. But there's many other LTP. So classically peach, we have in many countries. And when it comes to storage protein, obviously those are the protein that's causing allergy, like peanut protein, and there's component called RH1 and RH2. I'm not going to go in detail, but these are really important for the polysensitized patient. And this is a beautiful introduction to Dr. Immaculada talk. She's going to be talking about the polysensitized patient and how can we approach those patients. So you can see here those kind of the profiling together with multiple fruits and vegetables, and here you've got the PETV1 analog. Those names are the component of the protein. So usually I imagine the protein allergy like my hand, and here you've got every finger is a different protein. So if they're allergic to thumb, for example, that's a storage protein, they can develop severe anaphylaxis. But if they're allergic to the little finger, which is a profiling or PETV1, they were not going to develop that allergic symptoms or systemic symptoms. But again, that's a whole talk on food allergy we can talk about. The important bit is the patient can ask you at the end of the day, okay, doctor, the skin test is negative, but I still have got symptoms. I cannot enjoy Bahur, doctor. I cannot enjoy perfumes. What should I do? And that's obviously, he wanted treatment. My cousin came to you and you given them this sublingual tablets and did work. I want those tablets. And the patient comes to you like this, like, yeah, I've got that. I've got allergy, doctor. Your skin test may be not accurate, but we've done the skin test is negative. The blood test is negative. It still have the symptoms. There's plenty of other causes that related to rhinitis. So this is not allergic rhinitis, that's chronic rhinitis. And obviously, this is not an exhaustive list. This is just an example. The list is very long. Those patients usually need a very lovely ENT doctor that can just help take them forward for different treatment. So the whole idea of this session is to introduce you to the personalized treatment, to interventional treatment that we could do for this patient and improve their quality of life. But what we need to do is we need to have the right patient for this interventional therapy. We need to have the right patient to have the right treatment. So that's why we need to diagnose the right patient with the right diagnosis, not just anyone give them immunotherapy. We need to make sure we have that. So without further ado, I will stop here and I will hand over to my colleague Immaculada for her next talk.